only as case presentations. It will be short, it will be for 7 minutes, followed by 2 to 3 minutes discussion. So try to be on time. راح نستفتح بالدكتورة لارا رمضان. دكتورة لارا رمضان is fetal medicine specialist and the head of the fetal medicine department at Bashir Hospital. And she's gonna talk about Mickel-Gruber syndrome case presentation. تفضلي دكتورة لارا. قربي يا لارا أو افتحي الميكروفون.
هيك تمام. Good morning, dear colleagues. It's my great honor and pleasure to present my case in this prestigious conference. My presentation for today is Mickel-Gruber syndrome in 20 pregnancy, which is a rare lethal ciliopathic genetic disorder. In terms of pathogenesis, it's caused by mutations in genes encoding proteins that are structural and functional components of the primary cilium. As we see in the picture, the primary cilium is a single non-motile, hair-like projection found on the surface of most mammalian cells. Primary cilium functions mainly as a sensory organelle. It acts like antenna for the cell, detecting and transmitting signals from the extracellular environment. For classical manifestations, it's characterized by the classical triad: renal cystic dysplasia, which present in 100% of the cases, occipital encephalocele with incidence of 60 to 80%, and postaxial polydactyly in 55 to 75%. Okay. Moreover, there are other less common associated anomalies presenting in less than 30% of the cases, as hepatic developmental defects, CNS malformations, cardiac anomalies, and cleft palate, microophthalmia, macrognathia are also noted. This is a picture of Mickel-Gruber syndrome fetus. He has the 3 classical triads: occipital encephalocele, polydactyly, and renal cystic dysplasia. The main cause of mortality, it's often due to pulmonary hypoplasia, which is caused by oligohydramnios as a result of abnormal kidney functions. What about genetics in Mickel-Gruber syndrome? 14 different genetic mutations have been identified. That's why it shows extreme genetic heterogeneity and has a highly variable phenotype. It occurs equally the same in both sexes. Also, it has autosomal recessive pattern with risk of recurrence 25%. It has also a normal karyotype. The incidence of Mickel-Gruber syndrome, 1 in 13,250 to 1 in 140,000 live births across the globe. Just over 200 cases have been reported in the medical literature, but only a few cases documented in twins. When we come to regional variations, it's extremely wide due to consanguinity. For example, in North Africa, it's 1 in 3,500. And in Great Britain, it's 1 in 140,000 cases. Okay, now I will talk about the 3 hallmark anomalies that have to be emphasized. First one, cystic dysplasia of the kidneys. It's most characteristic and expected feature of Mickel-Gruber syndrome. The kidneys, as we see, it can be 10 to 20 times larger than their normal size, and on ultrasound, the kidneys filling almost the entire fetal abdomen. Okay. Second, occipital encephalocele. It's a cystic or solid mass in the posterior part of the skull containing CSF or brain tissue that has herniated through a defect in the occipital bone. This defect can be small or can be large, as you see in the picture. Okay, third one, postaxial polydactyly. As you know, there are 3 types of polydactyly: preaxial, central, and postaxial. But the one in Mickel-Gruber syndrome, it's postaxial, where the additional digit is on the ulnar margin of the hand, as you see in the picture. It can affect all 4 extremities, and it may not be detected in some patients. As we said, the incidence is only 55 to 75%. For diagnosis, we start first with early ultrasound screening in high-risk families, especially with consanguinity or a previous affected pregnancy. based on the presence of at least 2 out of the 3 classic major anomalies. Then we do genetic testing. Karyotype study should be also obtained to exclude chromosomal abnormality. For example, trisomy 13, because it's one of the differential diagnoses. MRI may contribute to the diagnosis, particularly in cases where oligohydramnios, where ultrasound is limited. Patient's profile of my case presentation. Ms. MH, who is 25 years old, female patient, presented to fetal medicine clinic at Al-Bashir Hospital on 27 of November, referred from her primary physician as a case of twins with suspected congenital anomalies. She had been married for 1 year with consanguinity marriage first degree. She's gravid to para 0+1 miscarriage. Her previous was a spontaneous monochorionic monoamnic twin pregnancy. Her LMP, 11 of July, 2024, gestational age at presentation was 19 plus 3 weeks. She had no medical illnesses and her surgical history, DNC, dilatation and curettage for her previous miscarriage. The ultrasound findings in both twins were monochorionic monoamnic twins. Both were alive. Fetal biometry was consistent with 18 weeks, severe oligohydramnios, polycystic kidneys, empty bladder, stomach was not visualized with hypoplastic lungs. Okay. In twin A, there was bilateral large kidneys with multiple irregular cysts. Moreover, small occipital encephalocele. But in twin B, kidneys were slightly enlarged with a few small cysts, with borderline ventriculomegaly and large cysts in the cerebellum. These findings illustrate the variability in phenotypic expressions, even with monochorionic twins. When it comes to management, thorough counseling was provided to the patient, including termination of a pregnancy, as these malformations are not compatible with extrauterine life. Revision of differential diagnosis of these malformations, we advised the patient for postnatal genetic testing, and we emphasized that continuation would not alter the outcome, but informed prenatal choice remained central. So after thorough counseling, the patient opted for termination. Then informed consent was obtained. The outcome was 2 male fetuses aborted. Both died shortly after birth. Genetic laboratory team was notified, and autopsy samples as skin tissue collected for genetic testing via whole exome sequencing. The results confirmed Meckel-Gruber syndrome, and advice given for the parents for PGD for future pregnancies. This is the picture of the genetic testing done for the patient with the result confirming the syndrome. Finally, to conclude, Meckel-Gruber syndrome is a rare lethal ciliopathy with no curative treatment. Early prenatal diagnosis remains the cornerstone for detection. Genetic counseling is essential, particularly in consanguineous populations. With a 25% recurrence risk, a preventive family-centered approach offers hope and reduces recurrence risk. Twin cases of Meckel-Gruber syndrome add complexity and highlights the need for further research. Thank you.
Thank you very much, Lara, for keeping with the time. And it's really a very interesting case presentation.
Thank you.
And the only thing we are always has to discuss is وهاي لازم احنا نشتغل فيها كجمعية انه نحاول ناخذ موافقة الدولة. اوكي احنا لانه نحن الشرع بيسمح لك بالتنزيل،
Yes.
الدولة لا تسمح لك، واذا صار في ميديكال ليجال مشكلة. فاحنا هلا ان شاء الله رح نحاول مع الدكتور احمد عبد الواحد نقوم بحملة ثانية نقنع البرلمان والأعيان والنواب بالموافقة at least on the lethal congenital abnormalities.
Yes.
فإن شاء الله رح ننجح نعمل هالشغلة هذه، لأن الشريعة بيسمح لك والدولة صار عندك مضاعفات رح توقف لك. فبالتالي أنا رأيي this is what we have to work on. وإن شاء الله we are planning something مع الدكتور أحمد عبد الواحد for next year. نحن أخذنا موافقتك أصلا من قبل، فنحن هلا الشرع الثاني أو شرع سوريا في عندك واحد ثاني واقف لك. Thank you very much, Lara.
Thank you for your attendance.
دكتور فلاح، دكتور دقيقة بالله يا لارا لو سمحتي. دكتور فلاح، هذا مونوكوريونيك دكتور فلاح.
لو كان التوم دايكورونيك دايامنيوتيك واحد منهم had the Mickel-Kruger syndrome
Yes.
with TANI normal, what will you do at this level at 18 weeks pregnancy?
Selective fetocide.
First of all, the most important thing is counseling with the patients, and it's dichorionic.
Diabetic dichorionic.
Dichorionic.
And one of them is
Selective
problematic.
I will not do
Have
anything,
PBL
just
or-
observation.
Selective fetocide.
You have two options. You have two
Yes,
options. You
yes.
can either do a feticide, selective
Yes.
feticide,
Selective,
but
yes.
given if these were dichorionic, one of them
Yes.
really affected with Mickel-Grouper will
Yes.
have severe anhydramness. Even if you continue, the risk of preterm labor is not really that high. So you could continue with both. You don't
Yes.
have to do selective feticide.
Yes.
Yeah, thank you. Thank you very much. We move to our next presenter, Dr. Ayman Khandaqji. He's a dear friend to the society, Dr. Ayman. He's a consultant radiologist and fetal medicine imaging specialist, especially with MRI. His case for today will be cases of fetal MRI. Yes, go ahead, Ayman.
صباح الخير. Good morning, everybody. We'll start with this image. It should be video. It is not. Okay. This is a fetus in the womb with MRI. He is moving, very active fetus, and this is against what we need during the examination. Purpose of fetal MRI. Used as adjunct to ultrasound when there are specific concerns or complex malformations that are difficult to evaluate with ultrasound alone. Advantages: superior soft tissue detail and contrast, excellent for detailed evaluation of the fetal brain, liver, kidneys, and other organs, overcome limitations of ultrasound such as maternal obesity or awkward fetal position, as well oligohydramnios. Can detect brain abnormalities not visible on ultrasound, such as those related to neural migration or myelination. More effective at identifying specific pathologies like dysgenesis of the corpus callosum and posterior fossa abnormalities. And it is very important also to evaluate placenta, as well placenta accreta and increta. Key indications for fetal MRI: CNS anomalies, thoracic and abdominal pathology, neck masses and soft tissue tumors, and placental disorders. Safety of MRI in pregnancy. It was well established that it is safe to be done after 18 weeks of gestation. In the first trimester period, it is not well established of its safety. Usually we ask the pregnant lady to come with fasting for 4 to 6 hours. So it is preferable to obtain our MRI fetal study early in the morning or immediately after she wake up. Usually we don't give any sedation for the pregnant lady, and the using of IV contrast gadolinium is contraindicated in pregnant ladies. Technical point, this will skip. This is the plain images of MRI. The main difference between MRI and ultrasound, in addition to other findings, that we can see the orthogonal planes. This is the axial, this is sagittal, and the third one is coronal, that they are essential in MRI. Whereas in ultrasound, we see usually 2D images. And if we need to have the 3D the third image, we apply the 3D protocol to see it. So it is indirectly seen. Agenesis of corpus callosum. This is ultrasound image for normal corpus callosum. It was done 3 days ago in my center. We can see the corpus callosum. I don't know, the arrow is... so in sagittal image, it is well delineated superior to the lateral ventricle. This case showed severe dilatation of both lateral ventricles. Usually the lateral ventricles, they are normal up to 10 millimeters. 10 to 12, it is mildly dilated. 13 to 15, moderately. And after that, severely dilatation. You can see here that on the right side slice or image, that the third ventricle is highly up oriented. The same picture on ultrasound. I'll skip this. This is the MRI. We start with taking this image for the pregnant lady, so we can see the fetus, the position of it. This one is cephalic in position. You can see the head is down. As well, we can see the placenta, it is posteriorly located. And then we start taking our images. This is the case. We can see that the same case that we showed ultrasound. that there are severe dilatation of both lateral ventricles, and on sagittal image, there is complete absence of corpus callosum. We can't see it along its anatomical place. The key MRI findings is unique and more obvious than ultrasound. Complete absence or partial formation of the corpus callosum on sagittal images, radial gyri arrangement, sunray appearance. This is the findings on agenesis. Colpocephaly, it is dilatation of the occipital horns of both lateral ventricles, high riding interposed third ventricle, identification of associated malformations like cortical dysplasia, cerebral hypoplasia, and abnormal white matter, which impact prognosis, as will the posterior fossa. Okay. This case was referred to me by my dear colleague, Dr. Maher Maaita. He saw that there is dilatation of both lateral ventricle with absent cavum septum pellucidum. When we did MRI, there was both lateral ventricles are oriented parallel to each other with dilatation of the posterior horns of both lateral ventricles, colpocephaly. This is oriented in the axial, then we have the coronal, and the diagnosis was established on sagittal images where the corpus callosum is completely absent, and we can see the sunray appearance on mid of the image. This is the same case in this image, and on the sagittal image, we can confirm our diagnosis. About the agenesis of corpus callosum, normally development of corpus callosum, it forms between 12 to 20 weeks of gestation, develop anterior to posterior, starting with geno, body, splenium, and rostrum, completed by 20 weeks of gestational age, so that the MRI is preferably to be done after that period. Types of agenesis, complete agenesis, entire corpus callosum is absent. We have partial agenesis, only anterior or posterior portions are absent, and hypogenesis or dysgenesis of the corpus callosum. MRI findings, there are direct signs, absence of corpus callosum along its anatomical place, no C-shaped callosal structure above the ventricles, and interhemispheric fissure extends deep between lateral ventricles. Indirect signs, as we said, colpocephaly, disproportionate enlargement of occipital horns, high third ventricle, high riding third ventricle, displaced superiorly, often interposed between lateral ventricles. Parallel orientation of lateral ventricles, normally the angle toward each other, radial arrangement of gyri along the interhemispheric fissure, sunray appearance due to absence of callosal fibers. Cystic structures, it is found in 10 to 20% of cases, interhemispheric cyst. Associated findings. This is the importance of MRI in such cases because these findings are difficult to be seen by ultrasound alone. We can see we should evaluate cortical malformations, polymicrogyria, heterotopia, and lysencephaly. We should evaluate the posterior fossa anomalies for vermis, intracranial lipomas, and the important to rule out chromosomal abnormalities, trisomy 8, 13, 18. So when diagnosed, the absence of corpus callosum, amniocentesis should be performed. This is technical prognosis. If it is isolated, the agenesis of corpus callosum, no other anomaly is found, and the chromosomal is normal, prognosis is often favorable. Many children have normal or near normal development, though subtle congenitive or behavior issues may arise. Non-isolated agenesis outcome depends on associated anomalies and genetic background. I have personally many cases, around 5 cases. They are 5 to 6 years and below ages, and they are developed normally till now. Key of MRI builds, always confirm on mid-sagittal view, absence of corpus callosum is diagnostic. Look for indirect ventricular signs, colpocephaly, parallel ventricles, elevated third ventricle. Always search for associated cortical and extracranial anomalies. This is another case. I skip immediately. So agenesis of corpus callosum, a congenital brain malformation where the corpus callosum is partially or completely absent, can range from agenesis to hypoplasia. Fetal MRI provides superior visualization of the callosal anatomy and associated anomalies compared to ultrasound. Fetal MRI has a greater sensitivity for detection of callosal agenesis. The direct signs, as we said, absence of corpus callosal in sagittal and coronal planes after 20 weeks of gestation. Indirect signs, parallel configuration of both lateral ventricles, midline lipoma or interhemispheric cyst. As we said, it is in 10% of cases. Many have abnormal cortical mantle, posterior fossa. In a study, it was around 40 to 47% associated abnormalities in the brain as well in the posterior fossa. Fetal agenesis of corpus callosum may be suspected on routine ultrasound, but required MRI confirmation, especially for prognosis and genetic consulting. MRI identified additional cerebral abnormalities, such as which significantly affect outcomes. Agenesis of corpus callosum is not always isolated. Up to 47 may have genetic cause identified. Isolated ACC can have a favorable prognosis, while associated anomalies worsen the outcome. The Society of Maternal Fetal Medicine recommends fetal MRI for further evaluation when agenesis of corpus callosum is suspected on ultrasound, as MRI findings can significantly impact the prognosis and clinical management. In this case, we can see on the second image that it is partially absent, as the posterior part of the corpus callosum is absent, whereas it is found anteriorly. And as summary, fetal MRI is a problem-solving tool. CNS anomalies are the most common indication. MRI change management in a significant minority of cases. MRI is most useful when ultrasound is inconclusive or when additional anatomical detail will impact the prognosis or delivery planning. Safety profile is excellent when performed appropriately. Avoid gadolinium. Thank you.
Thank you very much, دكتور أيمن. في حد عنده سؤال على أي شيء؟ تفضلي دكتورة.
يعطيك العافية دكتور أيمن. Very nice presentation actually. I have a comment for the fetal medicine. Usually when we do the detailed scan at 20 to 24 weeks, if we suspect any brain anomaly, we go first for advanced neurosonography, which is done at about 28 to 30 weeks, and this is done in whole by a transvaginal approach. If we suspect, of course, we could get the three planes you have mentioned, the axial, the sagittal, and even the coronal. It is very obvious by the transvaginal ultrasound because we go through either the anterior fontanelle or the posterior fontanelle. These are the windows through which we are examining the brain structures. If we suspect any abnormality during this examination between 28 and 30 weeks, we can go for the MRI after this time, not before, because the MRI is very helpful in cases, as you mentioned, of migration abnormalities, lysencephaly, heterotopia, polygyria, and so on. But MRI is very helpful for the fetal examination and detection of abnormalities which we cannot define or we cannot detect by ultrasound. Thank you.
I think this is a comment, not a question.
Yeah.
But anyhow, MRI.
بس هو يعني really إحنا عند الدكاترة بنخاف نحول.
MRI is safe to be done after 18 weeks of gestational age.
Yes.
So you can go off it. And whatever you do in ultrasound, it has its limitations, ultrasound. Definitely MRI is much superior to ultrasound in neuro in such cases, definitely.
MRI is an adjuvant to ultrasound.
Yes.
We do not deny
But when
this.
you have any...
And it is very helpful for diagnosis, as I said, of many cortical malformations. Sometimes we cannot, for example, the lysencephaly, it is difficult to diagnose sometimes.
But whenever you have an ultrasound, any abnormality in
Yes.
the brain, you should ask for brain MRI.
Yes, thank you
Even
very
if
much.
it is ventriculomegaly, simple ventriculomegaly?
Yes, of course.
Okay.
And I think this is an invitation for us.
Because
كلياتنا.
you can't
Yes,
rule
sorry.
out partial agenesis of corpus callosum. You can't rule it out. This is in ultrasound. Definitely, we can't rule out partial agenesis of corpus callosum or even complete agenesis of corpus callosum.
I agree with you, Doctor. Thank you very much, Umayya.
Thank you.
And I think this is an invitation for us as obstetrician to refer to fetal medicine specialists. Then definitely an MRI with a CNS abnormality will help a lot. Thank you. This is ما نحن قلنا obstetrician قلنا لا fetal medicine. fetal medicine صار عندنا عدد يعني هلا عم بكتر العدد ولا لا. انا رايي بالعكس لازم يكون في تحويل للفيتال ميديسن. fetal medicine هو definitely he's the one to share his opinion with the radiologist for the MRI. بس دكتور سامر كنت حابب تحكي شيء؟ معلش مع نسمع دكتور سامر. Short one please because of the time's sake.
Thank you. I very much enjoyed your nice presentation. I want to emphasize on the importance of comprehensive team approach to discuss those findings. We deal at our fetal care center exactly with the same protocol you have with doing fetal MRIs, but the parents of the children, they want counseling. So very important to involve a pediatric neurologist or a neurosurgeon in the counseling after the MRI results. Parents want to know complete agenesis versus partial agenesis. What does it mean 10 years from now? And at times we involve a pediatric neuropsychologist as well. So comprehensive team approach can be helpful as well by involving other specialties. Thank you.
Thank you, Samir. So we move to our third speaker for the case presentations. It is she's Dr. Soher Khotsiye. She's a maternal fetal medicine consultant. She graduated from New South Wales University in Australia. And she's going to present for us a case of Fraser syndrome.
Okay. Thank you, Doctor, and good morning, everyone. My case that I will present is a rare case of recurrent Fraser syndrome. Consent has been taken from the parents to present the images of their babies. This patient is a 22-year-old prima gravida with history of consanguinity, first-degree cousin, no family history of congenital anomalies, presented to the fetal clinic at 26 weeks gestation for anomaly scan due to severe oligohydramnios. The ultrasound findings were single umbilical artery, absent right kidney with atrophic left pelvic kidney and anhydramnios. Counseling was done about the findings and the prognosis. The patient continued her pregnancy, and she had a preterm vaginal delivery at 35 weeks. The outcome was male infant, expired shortly after birth, with multiple dysmorphic features and ambiguous genitalia. This is the image of the first baby for this lady. You can see here there's cryptophthalmus, syndactyly, low-set ears, and there was also ambiguous genitalia with micropenis, imperforated anus, and rocker bottom feet. This baby died 2 hours after delivery, and whole exome sequence was not performed. The patient presented in her next pregnancy earlier at 16 weeks gestational age, and the ultrasound showed single umbilical artery, elongated bladder, kidneys were present. Also, there was syndactyly. ما بيشتغل هذا الفيديو. Okay. You can see here there is syndactyly in the hands and also in the feet. Other findings, hyperechoic lungs, and also cryptophthalmus. This is also a video. anyhow. So the diagnosis for her second pregnancy was Fraser syndrome based on ultrasound findings and her previous history. The patient had antenatal counseling about the prognosis, and this is an autosomal recessive disease with a 25% risk of recurrence, and genetic confirmation is required. She had delivery at 36 weeks gestation with a stillborn baby, male baby. Similar anomalies to the first baby, cryptophthalmos and syndactyly. There was bladder herniation, laryngeal atresia, and umbilical hernia, and family declined WES. The third pregnancy, the same diagnosis, prenatal diagnosis was Fraser syndrome. The patient had delivery at 37 weeks gestation with a female baby, ambiguous genitalia, similar anomalies, cryptophthalmos, locet ears, syndactyly, renal agenesis, anhydramnios, Putter sequence, and umbilical hernia. And this baby died 8 hours later. These are the images of the third infant, cryptophthalmos, locet ears, Putter sequence, ambiguous genitalia, umbilical hernia, and partial syndactyly. WES was done for this baby. And it confirmed Fraser syndrome. So Fraser 1, homozygous, and Fraser syndrome. The other findings in the whole exome sequence for this baby, there was other additional 3 heterozygous abnormalities in other 3 genes, which needs further genetic testing. So extensive counseling was done for this patient. This patient, she had 3 babies died and no living children till now. So extensive genetic counseling was performed with a Zoom meeting with genetics from Saudi Arabia and from Jordan, and fetal medicine specialists, me and laboratory teams. And we advised the couple to do WES for both the mother and the father of the babies. Till now, unfortunately, they didn't do the WES due to financial constraints. Recommendations, pre-implantation genetic diagnosis, BGD, and prenatal diagnosis for future pregnancies. Short overview about Fraser syndrome. It's a rare with an incidence of 1 in 200,000 to 500,000 newborns. It's an autosomal recessive, and the gene mutation will be mostly FRAS1, and it could be FREM2 or GRIP1. And it affects the development of skin and connective tissue during embryonic development. The presentation, some cases are detected prenatally, as in these cases, due to ultrasound findings, abnormal ultrasound findings, like oligohydramnios, echogenic lungs, and renal abnormalities or agenesis. Most of the cases are diagnosed at birth due to characteristic dysmorphic features like cryptophthalmos, cutaneous syndactyly, genitourinary abnormalities, and respiratory tract abnormalities. The severity of the symptoms are variable. It could be fatal, or the child might live up to childhood or adulthood. Fraser syndrome could be fatal due to renal agenesis or laryngeal atresia. And there is no treatment for Fraser syndrome, no cure for Fraser syndrome. So the overview of this presentation, that this is a case of Fraser syndrome caused by, or Fraser syndrome is caused by mutation in FRAS1, FREM2, or GRIP1, and it affects the basement membrane formation and organ morphogenesis, and the key features, cryptophthalmos, syndactyly, renal agenesis, and genital anomalies. Thank you.
Anybody has any question? Dr. Falah, go ahead.
We offered termination, but the patients or the couple declined. The first presentation was at 26 weeks. So it was advanced, but they declined. Then later on, when they referred to us, we advised termination, but they declined, and they continued in their pregnancy. The other thing, they declined also WIS in the first baby and the second baby. They have denial that they have an abnormality, but in the third baby, they had WIS. WIS for the baby, we advised them to do WIS for the lady and her husband. Till now, they didn't do it. They said that they cannot afford it.
Yeah.
You monitor this baby during delivery,
I attended the third delivery.
vaginal delivery?
We
Normal
were
vaginal
planning the third delivery, the first and second were vaginal deliveries. The third delivery, the patient was very stressed and she refused to deliver the baby vaginally. So she insisted on cesarean section.
Yeah. Thank you very much.
Thank you.
Our fourth speaker is Dr. Shukran Suhair. Our fourth speaker is Dr. Omar Tasso. He's a fetal medicine consultant in Royal Medical Services, and he will talk about fetal neck teratoma.
Thank you. First of all, I would like the organizing committee for this wonderful invitations, Dr. Abir, Dr. Maher, who is my boss, my teacher, and who established the fetal medicine units in the Royal Medical Services. حاسس السقف بده يقع. طيب. My case presentations is fetal neck mass, huge neck mass in fetus, cystic hygroma versus teratoma or fetal goiter. 27 years old, medically free lady, referral to the fetal medicine unit due to suspected fetal neck mass at 22 weeks, previous to single vaginal delivery. On scan, there is a large mass, 10 by 10 centimeter, with cystic lesions and feeding vessels, extending anteriorly and causing neck distortion. MCA peak systolic velocity was normal, and there is mild polyhydramnios. The rest of the baby looks normal with the limit of gestation at that time. This is the mass anterior to the neck. There is, as we see, cystic lesions, large dominant cyst, and echogenicity. This is the feeding vessel. And this is the sagittal view of the mass at 28 weeks and 3 days. Again, this anterior to the neck coronal view with at 30 weeks and 3 days. At 30 weeks and 3 days, the size of the mass is 11 by 7. At 32 weeks and 3 days, the MCA peak systolic velocity just on the 95th centile with mild anemia and expected 12 hemoglobin of the fetus. 33 and 3 days. And as we see, there is a swallowing is present, but I think there is narrowing in this area due to compressions from the mass. The gestational age is 33 and 3 days. This is the vascularizations of the mass. So the differential diagnosis now between the fetal neck teratoma and cystic hygroma. 33 and 3 days, multiple cysts, septated, with dominant cyst, the largest one. The heart functions, the LV functions was normal, so no signs of hydrops or anemia, biphasic, and there's mild regurg, mitral regurg. Normal ductus venosus at 34 and 3 days. This is the severely extension of the cervical neck distortions due to pressure on the mass. 35 and 3 days. So the differential diagnosis, as we've said before, neck teratoma, cystic hygroma, fetal goiter. The neck teratoma is germ cell tumors originated from the germ cells, solid, large on ultrasound, and cystic masses, heterogeneous, with feeding vessels, and can cause hyperextension of the neck of course, complications, severe airway obstructions at delivery, polyhydramnios due to impaired swallowing, and we need an exit procedures at the time of delivery, and the outcome depends on the size of the tumors. This picture from the internet, this is neck teratoma. Again, it's from internet, and as we see, it could be similar to our case. Cystic hygroma, the origins is a lymphatic malformation due to abnormal jugular lymphatic sac development, multi-loculated cyst structures with thin septations, usually avascular and associated with trisomy 21, 18, 13, may resolve spontaneously, and the outcome depends on the underlying cause and the hydrops or fetal anemia. Fetal goiter, the origin from enlargement of thyroid gland, usually due to maternal Graves' disease. Ultrasound features symmetric, homogeneous anterior neck mass, usually solid, not cystic. Also can cause polyhydramnios due to impaired swallowing. This picture from internet, as we see, this is the goiter, and we can exclude from our case. We did an amniocentesis. We performed an amniocentesis for the lady, and the result came back with normal karyotyping. Then fortnightly follow-up till 36 plus 3 days, whereas at that time when there is a severe polyhydramnios with high MCA peak systolic velocity. Delivery with exit procedures and planned delivery after 36 weeks due to polyhydramnios. The baby was in breech presentation, so we planned for cesarean sections. Airway skewed and endotracheal tube. This is cesarean, and it's me. كيف بدنا نقدم الفيديو؟ كيف بدنا نقدم شوية؟ طيب هاي احنا شايفين السيزيريان. راح نطلع البيبي ونخلي البلاسينتا انسايتو وما نعمل كلامبينج للكورد لحد ما نحط التيوب. طبعا ويف كولد السينيورز بالاي ان تي، والسينيور اللي هو دكتور اياد الصفدي، والسينيورز التخدير، وكان في عندنا الفايبرو اوبتيك. خلص هو قصير اصلا. طيب هاي عندنا راح نشوف الان الفيتال نيك ماس. هسه بنحاول نعمل intubations واحنا ready for التريكوستومي. الintubation was difficult due to the mass. هو 3 دقائق بس مش عارفين نقدم الفيديو. اللي انتي for tracheostomy. لا هيز ريدي. الدكتور اياد كان هذا مش انتي التخدير. هو كان موجود بس يعني opted انه يكون فور تريكستوم مش على التيوب. طيب هاي التيوب ان. طيب تاكدنا انه التيوب ان. هلا بنعمل كلامبينج هاي بسموها الاكزيت بروسيجر بالماسز لما يكون في ديستورشنز للنك. موجود كان كمان كلهم كان. طيب هلا بنعمل كلامبينج للكورد. هي طلعنا البيبي. بنعمل كلامبينج للامبليكال كورد. هيك متاكد انه ما راح ياخذ بريذنج وما يصير عنده. خلص هيك اعطيناهم البيبي. شغل نظيف. طيب. طيب هاي البيبي هون intubated. Now التريتمنت هلا definitely شو بتعتقد دكتور ماهر، شو رايك؟ شو الماس هاي جروما ولا خلص. السيستيك هايجروما التريتمنت إلها اللي هي surgical excisions is the main treatment. Sclerotherapy with bleomycin, doxycyclines or OX432 can shrink the lesions often used in large or complex cases. وطبعا the prognosis depends on associated anomalies and whether hydrops is present. هاي السيتي سكان تبعت البيبي post delivery، شايفين الماس قديش كبيره، وهاي الاكس راي لما كان التيوب موجود، وهاي الماس هي هم مبينه كمان. طيب البوست ناتال مانجمنت اكيد كان البيدياتريك سيرجيكال تيم انفولد، والايمجينج كونفيرم سيستيك هايجروما، والبرايمري سيرجري واز اسبيريشنز اندر سيديشنز للسيستيك ليجنز للدومينانت سيست، واعطيناها بليومايسين انجكشن. الاوتكم طبعا الفاينل ديagnosis سيستيك هايجروما، وعلى 4 مانثس البيبي اكتف وويل واويتنج فور ديفينيتيف سيرجري. هي البيبي على الخمس اشهر، لافلي بيبي ستيل لسه في ماس هنا، طبعا هي بنوته شكل هلا لابسه احمر ها لا لسه لا في سيرجري، بس بستنوا لما يصير شرينكج لكل السيست. لسه على المؤتمر الجاي بتكون عملت وتكون صبيه بجيبها معي على المؤتمر. طيب الكونكلوجنز الامبورتنس اوف prenatal diagnosis and MDT planning والexit procedures ensure safe airway favor neonatal outcome despite large neck mass زي ما كان بحالتنا. Thank you for your worship. Thank you so much.
بس بدي اسال على التوكسيسيتي اوف بليومايسين، في توكسيسيتي على نيونيت ولا لا؟ حتى لو I know it's local what any yeah it has to be discussed with the family. تفضل دكتور أيمن.
Thank you. I think this is a typical case for the benefit of MRI in such a case. Definitely the ultrasound has limitation and we see the images. You can't see all the fetus. Definitely if we did MRI for this case, you will much evaluate the situation. The parents will be more oriented about what they are facing and also the management after delivery. So the fetal MRI is very important in such case. Please ask for MRI, don't hesitate. But you should know where to refer your pregnant lady for a center that they have experience in such fetal MRI. This is the first, yeah.
Yeah, but does the MRI change the decisions for exit procedure or not? The most important for obstetricians is to ensure that the airway is open or not. But post-delivery, we need MRI of course to ensure يعني to definite diagnosis. But in utero أنا بيهمني as obstetricians و fetal medicine need for exit procedure، لأنه exit procedures بدك تنادي MDT، تنادي التيم كامل. بس هاي هي. Does that change؟ يعني can see the esophagus on MRI؟
Sometimes we can see it.
Okay.
And you saw cine images for the fetus while he's moving, sometimes
Yeah.
where he's swallowing. And the management will be much better for orientation for everybody, even for surgery.
Thank you.
Yeah.
Second,
Thank you.
why you ask for CT scan after delivery? This is not.
I don't ask
this
for
is not-
CT scan. That's by
but
pediatricians.
something to
Yes.
attend that CT scan, we are very
I know.
cautious about radiation.
Yeah.
And the MRI is much better in such cases than CT scan.
Yes. Yes. Postnatal is by. Thank you, Dr. Ayman.
Dr. Elisa has a comment or a question. Go ahead, please.
Of course.
In our unit at Tommy's in London, whenever we do exit procedures, they all get a fetal MRI actually, and it does change management because potentially we have quite a large referral catchment area, and it helps to assess patency of the airway. So they make the decision from the peripheral units whether they can be delivered locally or they can be delivered in our unit based on airway patency, which we see on the MRI scan. But thank you.
Dr. Lisa, do you do an exit procedures on vaginal delivery also?
No, we only do them at cesarean sections.
Thank you.
Thank you.
Yeah. Thank you very much, Dr. Umar. Shukran. I'm going to leave the microphone for Dr. Osama Habaib, my colleague, to finish the case presentations.
Okay. I would like to invite Dr. Umayma Darode, who's a consultant in obstetrics and gynecology and a subspecialist in maternal fetal medicine, who's going to present an interesting case of prenatal detection of CHDD with a novel gene variant. Thank you, Doctor.
Good morning, everybody. لما حكى معي الدكتور ماهر المعاطى قبل المؤتمر كان بيحضر في برنامج المؤتمر بيحكي لي بيقول لي البرزنتيشن تبعتك التايتل تبعها كتير طويل شو بدي اعمل فيها كيف بدي اكتبها قلت له اختصر اسم الديس اوردر ل SHDD فهدول الدكاتره اللي سالوني الزملاء والزميلات شو اسم الديس اوردر هذا هو كان اختصار له So my presentation will be about prenatal detection of a novel gene variant in Silverman handmaker dysegmental dysplasia. So Silverman handmaker dysegmental dysplasia is a rare and severe genetic disorder that affects the development of the bones and cartilage. It has a high risk of stillbirth or early death. New genetic mutations are constantly being discovered, and this presentation will focus on a specific, previously unreported variant identified through prenatal testing. This highlights the cutting-edge nature of the research and its importance in genetic diagnostics. So our patient is a 21-year-old pregnant lady, gravida 2 para 1 with one healthy child, consanguineous marriage. She was referred at 17 weeks of gestation due to detection of severe shortening of fetal limbs. Her medical and family history were irrelevant. The detailed ultrasound examination revealed the following findings. First of all, the fetus was growth restricted with an estimated fetal weight below the first centile. There was severe micrognathia and short neck, as you can see from the 2D image on the right side here. There was an occipital encaphalocele which explains the microcephaly. It is obvious here in the video clip and in the 2D image. The upper limbs were in affix deflection. It is obvious in the 3D image, the video clip here, and the 2D image. There was severe tetramicromelia with bilateral severe rhizo-meso-acromialic shortening in the upper and lower limbs, which means that the 3 segments of all the bones were short. There was campomelia with bowing of the lower limbs and prominent eyes, as you can see here. The thorax was narrow. It is obvious in the sagittal plane and in the transverse plane. And the vertebral bodies were disorganized, especially in the lower lumbar region, as you can see here and there. A provisional diagnosis of skeletal dysplasia was made, and the couple was counseled regarding the severity of the abnormalities and the need for further genetic studies. Amniocentesis for whole exome sequencing was performed, which showed a homozygous pathogenic novel variant in the HSPG2 gene, which is consistent with the genetic diagnosis of autosomal recessive Silverman handmaker dysegmental dysplasia. To the best of our knowledge, the HSPG2 variant of this mutation is a novel variant not previously reported in the literature. The mutation was a substitution of a guanine to an adenine at the first position of the intron following nucleotide 11565 of the HSPG2 gene's coding sequence. The couple opted for termination of pregnancy, however, they denied fetal autopsy. Medical termination was done, and the external examination of the abortus showed the following findings: facial dysmorphism, very short neck, micrognathia, flexed short upper and lower limbs, equinoverse deformity, and occipital encephalocele, as you can see from the images of the abortus here and there. 1 year later, the mother gave birth to a completely healthy baby girl after a spontaneous pregnancy. So this presentation addresses the limited information on the prenatal diagnosis of DDSH. It emphasizes the critical role of detailed sonographic evaluation and the use of molecular testing to confirm the diagnosis and determine the best course of management. Actually, we have two recognized subtypes of this segmental dysplasia: the severe lethal form, which is our case, the Silverman handmaker, and a milder form, which is the Roland dysbucois. The segmental dysplasia Silverman handmaker type was initially described by Handmaker and colleagues about 40 years ago. It is an extremely rare skeletal dysplasia caused by functional null mutations in the Perlecan gene with an incidence of less than 1 in a million. It is, as I said, autosomal recessive, and the individuals with DDSH have flat face, micrognathia, cleft palate, narrow thorax, highly reduced joint mobility, encephalocele, club feet, and the vertebral bodies have multiple patchy and irregular ossification center defects, hence the term dyssegmental dysplasia. To date, only 6 cases of molecularly confirmed DDSH have been reported in the literature. Of these 6 cases, only 4 were prenatally detected, making our case the 5th prenatally detected case. The molecular test of choice is WIS, whole exome sequencing, and prenatal diagnosis is important in this type of lethal dyssegmental dysplasia to help make an informed decision and accordingly plan future pregnancy. The vast majority of patients with DDSH have died in the immediate perinatal period. However, Bravo et al. Reported the longest survival case of clinically diagnosed DDSH at 8 months of age. But as I said, it was just clinically diagnosed without molecular confirmation, which sheds doubt on the reliability of diagnosis in this case. The differential diagnosis includes fibrochondrogenesis, which is characterized by rhizomelic shortening, which means that only the proximal segment of the limb is shortened. The chondrodysplasia punctata, which is characterized by stippled epiphyses, and Wissenbacher-Zollmuller syndrome, which is characterized by rhizomelic dwarfism and severe hearing loss. And interestingly, these babies, they catch up growth 2 to 3 years later. So our case contributes to the limited body of literature on DDSH by highlighting a novel mutation, expanding the non-phenotypic and genotypic spectrum of this condition. Given the severe prognosis of DDSH and its autosomal recessive inheritance pattern, accurate and timely diagnosis is crucial for appropriate management, as well as for family counseling regarding the high recurrence risk and the option of pre-implantation genetic diagnosis in future pregnancies. Advances in molecular diagnostics such as WIS are increasingly valuable in the diagnosis of rare skeletal dysplasias and may facilitate earlier and more accurate identification of DDSH, which remains a challenging diagnosis, particularly prenatally, due to its rarity and phenotypic variability. Increased awareness of its characteristic features is essential for accurate identification. And thank you.
Thank you, Dr. Umayya. Thank you for you all for these nice presentations. I have only one comment. It is rather than a question. We look for Dr. Umayya case, Dr. Suhair. All these patients, I think we should do something for them regarding their need for PGD. Our patients, not all Jordanians can pay for PGD to have children. So Dr. Suhair case has 3 dead babies. This is a catastrophe, actually, for this patient, and she cannot offer, or she cannot be offered to have PGD. So I think we should, or we have to work on this point regarding our patients, regarding the need for PGD, the patients who have some element of consanguinity and there is a genetic problem and they need to do PGD to have babies. So I think it to somehow need to be free, yes, free, or something discounted. Okay, thank you.
You are absolutely right, Doctora. Actually, it is advised that at least some institution, for example, the public sector, can offer the genetic study for the patients with at least a list price maybe, or a discounted price, or for insured patients to give them for free. Otherwise, we cannot get the diagnosis of every case, because actually the consanguinity in Jordan and in Middle East in general is very high. So we are faced every day with congenital diseases and genetic diseases which are congenital and inherited. So we should do something for at least documentation of
Keeps
these
us
cases
in business.
to be able to prevent these cases in future. Thank you.
Thank you. Next, I'm inviting Dr. Lisa Story, who is a clinical academic. She's a senior lecturer at King's College Hospital College in London and a consultant in obstetrics and fetal medicine at St. Thomas's in London. Dr. Lisa's main research focuses on the use of fetal MRI in high-risk pregnancies, as well as management of women at high risk of preterm birth and pre-labor rupture of membranes. And she's going to talk to us firstly about prediction, prevention, and optimization for preterm birth. Thank you.
So thank you very much. It's an absolute honour to be here. My name's Lisa Story. I'm a clinical academic. I'm a reader or associate professor in maternal fetal medicine, and I'm a consultant in obstetrics. So today, in the first session, I'm just going to talk about advances in detection and prediction of preterm birth. Oh. Is that better? Yeah, perfect. Okay. So I'm sure everyone here is very well aware that preterm birth is a very significant global health problem. Although it's defined as delivery before 37 weeks gestation, it's actually the infants that are born before 32 weeks that go on to have the most significant adverse outcomes. So if you look at complications that survivors face, about 6% of those children go on to develop cerebral palsy. About half of them have some other neurodevelopmental problem. And then there are other complications as well, like bronchopulmonary dysplasia or a need for supplemental oxygen. Also, they get things like necrotizing enterocolitis, retinopathy of prematurity. Obviously, that has massive impact for individuals and their families. But also the economic consequences are really significant. So this is just a very rough approximation of the cost to the NHS per year of common conditions. And you can see that actually preterm birth is very comparable to alcohol and smoking. And actually the costs are probably even greater than this, because this graph only takes into account what that costs to caring for these children to the age of 18. And actually some of these individuals go on to need lifelong care. So in terms of outcomes, adverse outcomes are inversely proportional to the gestational age at delivery. So this is a graph just looking at UK data. On the left, you can see the orange line is the live-borns that then subsequently die, and you can see it's very high, as you would expect, at 22 weeks, and then it comes down towards term. And the blue lines basically represent the number of live births at each gestational age. So again, as you would expect, at 22 weeks, very few babies are surviving, and most of the babies that deliver are clustered around term. So on the left here, you can see a demographic from the British Association of Perinatal Medicine. And I think it makes the point really nicely about how if you can defer delivery, even by a couple of weeks, you can actually make a massive impact on outcomes. So if you take all of the infants born in the UK, 7 out of 10 of the babies that are born at 22 weeks don't survive. And of the ones that do, 1 in 3 go on to have very significant disability. But even 4 weeks later, by the time you get to 26 weeks, the majority of those children are surviving, sort of 80%, and only 1 in 10 have significant disability. So again, that makes a really, really big impact. So part of the problem when we're trying to address preterm birth is that we don't really understand what causes it. We know that it's multifactorial and probably these factors interplay with each other. But we do know that particularly at the early gestations, infection and inflammation play a really big part. There are other hypotheses too, so cervical damage. So that can be things like LETS procedures, cone biopsies for abnormal smear tests, but also more recently caesarean sections at full dilatation, which I'll talk about in another lecture later today. Then you've got anything that stretches the uterus, so polyhydramnios, multiple pregnancies. And then there are other just general factors like maternal health, certain maternal conditions, being exposed to domestic violence also increases your risk. So really, given the magnitude of this problem, the government in the UK has identified it as a priority, and it has an ambition to reduce the preterm birth rate from 8 to 6%, which actually is no mean feat at all. And as a result of that, a number of different guidelines have been implemented recently or updated, really to try and tackle this problem and to get those preterm birth rates down. And I'm just going to talk a little bit about the themes of those today. So basically, all of these documents really focus on 3 aspects of care. So firstly, it's predicting which women are at highest risk of preterm delivery. Then it's targeting interventions to try and prevent preterm birth. And the final arm is really to try and optimize the state of the baby if, despite your best efforts, a woman still presents in preterm labor. So that's transitioning to thinking about things like giving steroids, giving magnesium sulfate for neuroprotection, and also just simple things like making sure the woman delivers in the right hospital with the appropriate neonatal facilities. So starting off with prediction. So I think prediction actually needs a really coordinated approach between community and hospital services. So it's about risk stratifying every woman at their booking visit. So it's not just about identifying women who've had a previous preterm delivery, it's about all of those other kind of softer markers as well. So for example, if you just take smoking as an example, if you have a woman who's had a previous preterm delivery and is a smoker, she's 50% more likely to deliver preterm than a non-smoker. But actually, if she gives up smoking in the first or second trimester, she brings her risk back down to that of a non-smoker. So things like that can actually make a really massive difference. So in the UK as well, we also think about women who have risk factors like complex social needs, if they've been exposed to domestic violence, extremes of maternal age. We have specialist midwifery teams who look after these women and make sure that they're kind of cared for in the appropriate pathways. So then you have the women who have very overt risk factors for preterm birth. And in the UK, we now have preterm birth clinics in every maternity unit. And actually just having preterm birth clinics or a designated clinic has a massive impact as well. So there's really good data from Australia where they looked at their preterm birth rates before and after introduction of preterm birth clinics, and they actually found that they can reduce preterm birth rates by 22%. So again, just having coordinated services makes a difference. So in these clinics, what do? Well, we do things like we risk stratify even further. So we do cervical length scanning, and sometimes we use other adjuvants as well, like fibronectin, which I'll talk about in a second. So this is the UK care pathways for preterm birth. And basically it stratifies women at high risk into two streams. So firstly, you have the high risk group. So these are women who've had a previous preterm birth or late miscarriage between 16 and 34 weeks gestation. Women who've had significant excisional procedures of their cervix, so for example, trachelectomy for cervical cancers. Women who've had a previous preterm rupture of membranes before 34 weeks, even if they then subsequently deliver at term. Known uterine abnormalities like bicornuate or didelphys uterus, and also Asherman syndrome. So for those high-risk women, we have to have at least referred them to the preterm birth clinic by 12 weeks, and we hope to have had their first appointment by 16 weeks. And then we discuss and talk about interventions. So for the second group, these are determined to be intermediate risk. So they're people like women who've had a previous full dilatation cesarean section or who've had significant excisional treatments to the cervix. They fall under the intermediate pathway. I have to say in my unit, we do actually see them all in the preterm birth clinic still, but actually many units will just get them to do a cervical length scan at the time of their anatomy scan, and then they decide if the cervix is short, they go into the preterm birth clinic, and if it's of a normal length, then they go back to low-risk care pathways. So just a little bit about cervical length screening. So for the high-risk women, a minimum we do it at 16 and 22 weeks, but more often as indicated. And the intermediate risk women we do once, and then follow up accordingly. So this is just a picture here of a cervical length measurement. So we're measuring from the internal to the external os. We measure as a straight line, but some groups trace through the canal as well. But in singleton pregnancies, less than 25 millimetres is considered to be short. So currently, in the UK, we don't routinely screen all low-risk women with cervical length screening, and that's really based on a Cochrane review by Bergella et al. Back in 2019. But that is quite a small data set, and that's certainly something that's under review at the moment. There's an NIHR-funded study that's about to start, just to look at the utility of screening low-risk women. Within the preterm birth clinics as well, we risk stratify further. So we have something called the QUIP app. So this is freely available to download from the App Store, and there's an Android equivalent as well. And basically, it's a validated algorithm that takes into account the woman's history, the cervical length scan, and you can use it with fetal fibronectin, which is a vaginal biomarker. The only issue with that is it's currently not being produced at the moment, but the app works perfectly well without it. And what it does is it basically gives you a risk that the woman's going to deliver in the next week, 2 weeks, or 4 weeks. And that means, again, that you can then target your interventions a little bit more accurately. So, for example, it might help you decide when you need to bring them back to the clinic. When they're getting around periviable gestations, when to target steroids, and also if you need to transfer or admit to hospital. So basically, then we need to think about preventative strategies. So we've got our high-risk group, but what can we do about it? And I think it essentially comes down to two main treatments now. So the first is progesterone, and the second is cervical cerclage. Actually, Arabin pessary is here, but recent data indicates that actually potentially Arabin pessaries can do more harm than good. So we certainly don't use them anymore in our unit. But starting with progesterone, so progesterone, obviously it's a hormone that's produced by the body, and when we give it exogenously, it comes in two main forms. So there's natural progesterone, so that's typically the vaginal preparation. It's often given in a micronized form, something like cyclogest, and then there's semi-synthetic, which is 17-OHPC, the intramuscular injection. So the best data we really have about the use of progesterone in women at high risk of preterm birth is from the EPIC meta-analysis. So this was a Lancet study which uses individual patient data of more than 11,000 women. And what it found was that actually both vaginal progesterone and 17-OHP-C reduced the risk of preterm birth before 34 weeks in women who were at high risk of preterm delivery. So that includes women who had a short cervix and women who had a previous history. And actually the data was more compelling for women with both a short cervix and previous preterm birth. And just history alone, it isn't quite so clear, but certainly NICE guidelines in the UK say that we would offer all women who've had a previous preterm birth prophylactic vaginal progesterone, and we give a dose of 200 milligrams once a day in the evening, really because that's the dose that most of the studies have been conducted on. The other thing just to say is that actually in the US, they've withdrawn the license for 17-OHP-C, and that was partly due to the fact that it didn't really show significant efficacy from one of the trials. But also, the European Medicine Agency has also withdrawn 17-OHP-C, and that was based on two factors. So firstly, this kind of data that maybe it isn't quite as effective, but secondly, the fact that there was a population study that was published a couple of years ago, which actually said that potentially 17-OHP-C increases all cancers in the offspring. It's a small effect, but the combination of the two, the fact that potentially it wasn't quite as effective, meant that they don't support the use of 17-OHP-C, but they do still support vaginal progesterone. So then going on to what do you do with multiple pregnancies. So it's a little less clear with multiples. But basically the EPIC meta-analysis also looked at twin pregnancies. But most of the women in this actually had only having a multiple pregnancy as their risk factor. So they hadn't had preterm deliveries, they didn't have a short cervix. And what it found that there wasn't an effect. And more than that, it potentially increased the risk of preprom for the women who were exposed to 17-OHP-C. So following on from that, there have been some meta-analyses that were conducted taking women who had a short cervix with multiple pregnancies. Initially, when the meta-analysis was published, it had just over 300 women and showed that it did reduce the rate of preterm birth before 33 weeks in these women. But one of the studies had to be retracted due to concerns over methodology. So the analysis was repeated, but it only has 90 women in it now. So how big this effect is, we don't know. But again, it's in UK guidance now that we offer women with a short cervix with twin pregnancies progesterone. So I think when you're giving any drug to women who are pregnant, they're understandably always a bit worried about side effects for their baby. And actually, there's quite good data now that's coming out on the long-term effects of progesterone. And certainly if you follow those children up to 8 years, there's no effect in terms of neurodevelopment for those children. From my perspective, I think it's going to be the really interesting thing is when these cohorts hit puberty, because we don't know what the effect progesterone has there. But again, we're kind of waiting for that data to come through. But I'm sure if it was anything significant, we would have heard about it by now. So next, going on to cervical cerclage. So this is probably the most established preventative treatment for preterm birth prevention, first performed in about the 1950s. And you can categorize it in different ways, but basically we have history indicated stitches, which are put in almost preventatively. We always wait in our unit until they've had their 12-week scan, just in case there are any issues that are picked up there, or they have a first trimester miscarriage. But when you look at the data, actually the only women who really benefit from putting it in preventatively are women who've had 3 or more preterm births or second trimester losses. And that sounds quite harsh as a statement when you first make it, but it's not that you're withholding the best treatment from everybody. It's more that actually for most women, you'll get exactly the same outcome by following the cervix with ultrasound as you do putting in a prophylactic stitch. And actually then you don't expose them to the risks of the anesthetic, it's a foreign body, all of those kind of things as well. Then the second group is the ultrasound indicated stitch. So in high risk women, having a cervix less than 25 millimeters would indicate offering them a cervical cerclage. In terms of low-risk women, if you incidentally find a short cervix, what do you do? Well, actually, there's a paper from ACTA. It's a retrospective study by Suka in 2020, and it showed that actually you only really benefit from the stitch if the cervix is very short, less than 8 millimeters. And if we incidentally pick up a short cervix, we tend to offer progesterone as our first line, unless it's less than 8 millimeters. Then we have rescue stitches. So this is where the cervix is exposed. In singleton pregnancies, it prolongs the pregnancy by about 50 days or so, but you have to select the women very carefully, particularly making sure they don't have subclinical chorioamnionitis. And we've certainly seen a case in our unit where a woman had a rescue stitch and ended up with such significant sepsis, she ended up needing a renal transplant. So, you know, selecting these cases for rescue isn't as straightforward as it initially seems. And then the final type is a transabdominal cerclage, which I'll cover more later today. But the evidence for this is really women who have a failed history or ultrasound indicated stitch. And as I said, I'll go into that later. So thinking about cerclage and multiples, again, the evidence isn't as clear here. So the initial studies really showed that there wasn't any benefit if you take the same cutoff as you do for singletons of 25 millimeters. But actually, further data has come out that if you have a lower cutoff at 15 millimeters, that potentially does confer benefit. And in terms of rescue cerclage, they do seem to be effective in these women. They potentially don't prolong the pregnancy quite as much as they do in singletons. But again, we would definitely offer them to women if they had a short cervix. And in our unit, we only put stitches in up until 24 weeks. NICE guidelines say you can consider rescue stitches between 24 and 28. But to be honest, the risk of rupturing the membranes and all of those things, we tend not to do them in our unit. So just some brief slide on some other issues about cerclage. So there's always the question, Shirodka or McDonald. And actually, interestingly, a small RCT didn't actually find any difference between the technique. We only tend to put Shirodkas in when you can't get to you can't put this stitch vaginally. So for example, if they've had a LETS procedure and there isn't much of the cervix actually visible in the vagina. But the really important thing, whichever approach you go, is to try and get the stitch as high as you possibly can. Then thinking about suture materials, some units use monofill, some braided merceline tape, and actually the data shows there isn't really much difference between the two. The interesting thing I think that's kind of watched this space at the moment is which is better, progesterone or cerclage. I'll cover that in the next slide, but what about giving both together? And actually there's a subgroup analysis of that C-stitch study, which you can access on a preprint server, that's actually indicating that maybe combination therapy is actually better than one alone. But we ran a study called Support from KCL, which was a multi-center study looking at randomizing women to stitch progesterone or arabin pessary. And we actually found that there wasn't a difference between the two. But as I said, data subsequently come through about the arabin pessary, which is questioning its safety. So finally, just thinking about optimization. So despite your best efforts, these don't always work, and people may actually present in preterm labor. And what do you do then? Then I think the focus shifts on optimizing outcomes for the baby. So it's things like giving corticosteroids, magnesium sulfate, tocolysis, and making sure they deliver in the right unit. And actually, the data for the last point is so compelling because the outcomes are so much better if you transfer that woman in utero as opposed to the baby ex utero. So again, steroids, I think it's a well-established intervention. The latest Cochrane review was in 2020, looking at delivery before 37 weeks. And again, there's very compelling evidence that they reduce the risk of perinatal death, they reduce neonatal death, respiratory distress syndrome, and are likely to impact rates of intraventricular hemorrhage and neurodevelopmental delay as well. We give them up until 34 weeks, and we consider until 36, which is in line with the NICE guidance. I think giving second dose is a bit more controversial. There was a Cochrane review in 2022, which indicated that they do still reduce respiratory distress syndrome and potentially improve a composite neonatal outcome score. But the worry is if you give repeated doses, it has effect on neurodevelopmental delay. And there are disadvantages. Potentially, they affect glucose tolerance. If you give the steroids and they don't deliver within 7 days, it potentially causes a reduction in birth weight. And we don't tend to give them for our late elective cesarean sections either for these reasons. Then thinking about magnesium sulfate. So I think the magnesium sulfate story is a really, really interesting one. So the reason we give magnesium sulfate isn't actually anything to do with spontaneous preterm birth. It's actually based on data from women with preterm preeclampsia, where the women received magnesium sulfate for FIT prophylaxis. So they realized when they looked at this data that actually the women that had been exposed to magnesium had a reduction in rates of cerebral palsy. And as a result of that, they actually introduced it into standard practice for spontaneous preterm birth, but it's actually a completely different condition. But actually, so we tend to just use the same protocols as we do for women with preeclampsia, but whether that's completely right or not, we're not sure. But it does seem to reduce the incidence of cerebral palsy under 34 weeks with a number needed to treat of 41. And actually that effect is more pronounced the earlier the women are. So again, I think it's an interesting story. Sorry, that's a 3D brain. But and tocolysis, I guess, is the next question. I think there's actually no evidence that tocolysis has any direct favourable effect on neonatal outcomes at all. Its real utility is firstly allowing steroids to have time to work, and secondly allowing time to get that woman to the right facility. There's a really good individual patient data meta-analysis by the Birmingham group in the UK, looking at all of the outcomes for tocolysis if anyone's interested. And certainly nifedipine is recommended by many organisations like the RCOG and the WHO as the first line. It's cheap, it's easily accessible, and it works. And atosiban is a second line. Obviously it's more expensive, but it's quite good for women who have like cardiac disease or anything where you don't want to have significant effects on maternal blood pressure. So that was a bit of a whistle-stop tour, but in conclusion, you know, preterm birth is a significant global health issue. But actually, by really thinking about these three measures: prediction, prevention, optimization, you can have a significant impact on outcomes. So yes, I'm very happy to take any questions. But thank you very much.
Thank you for this excellent presentation, Dr. Maher.
Can I just ask you, in terms of management, you mentioned tocolytics, you mentioned steroids, magnesium sulfate. Now, do you give the same protocol as preeclampsia, a loading dose and then maintenance for 24 hours? And the other question, do you give any antibiotics? Because you know there is evidence in the States now, we're going back to the antibiotics era and giving more than one antibiotic in those cases. So I just want to know your protocol. Thank you.
Yeah, no, that's a great question. So we don't give antibiotics unless they're actually in preterm labour. So we give benzyl penicillin if the woman's actually contracting and about to deliver. But I know the data from Romero is quite interesting, looking at sludge and things like that, because they are giving antibiotics in that situation. But we haven't started doing that yet. but an interesting point. I'm so sorry, you had another question, but I've completely forgotten what it was. Magnesium, yes. So we give exactly the same protocol as preeclampsia, but I'm not convinced it's right. But yes. Sorry.
A quick question, please. The role of recurrent and combination therapy in recurrent failure, the role of endoseed or endomethacin.
Yeah, so we don't.
The regime of and how long we can prescribe.
We don't tend to give endomethacin at all, to be honest. I know that some groups give it at the time of putting in a cerclage, just as a tocolytic more than anything. But I think just because of side effects of it, we don't tend to give it. And again, when you look at the data on endomethacin in that individual patient data meta-analysis, it's not that effective, essentially.
Last week, I have seen one case, one of my colleagues, not me, she gave nifedipine at 28 weeks. And nifedipine, she used to give 20 milligrams slow release. After 2 hours, given another dose. The problem that the patient has hypotension, and she was given saline IV. What is the recommended dose?
Yeah, so we do actually do the same thing. It's 20 milligrams. And we give it, I think, every 2 hours. We very rarely give it, actually. And I think the reason we don't give it is because we're the tertiary referral unit, so we don't really need to transfer people. But actually, when you look at when you should give tocolysis, actually, the guidelines say you shouldn't be giving it at all until they're actually in labour, so at 4 centimetres. So, you know, it's a really, really interesting question, but I think your point about hypertension is a really, really good one. So in some women are particularly sensitive to it, but some tolerate it much better. But I think that's why atosiban is also recommended, because it doesn't have those same effects on blood pressure. And I think the reason the WHO only recommends nifedipine in preference to atosiban is more the fact that it's cheaper and it's more readily available worldwide, really. So it's a cost-benefit effectiveness. Thank you.
Thank you very much for your very interesting lecture. I understand there is, once preterm labor started, it will be so difficult to stop it. And those who say, I stop it with the, whatever use the beta-mimetics, atosiban or whatever, maybe they have wrong diagnosis from the start. Because 50% of those who are diagnosed as preterm labor, they prove to be not in a preterm labor. Because if you leave them alone, some of them, there is a lot of randomized study. If you leave those who present to emergency or obstetric units, some of them, they don't, 50% or 40 to 50%, they don't deliver up to 7 to 14 days.
Yeah.
And some women who come, even with mild labor, they may proceed to labor even without any intervention. That's my point. In my opinion, we should concentrate on the prevention, and we should concentrate on screening of women. You mentioned about fetal fibronectin. Unfortunately, it's not available in Jordan. I don't know if it is available in all centers in UK, although I worked in very respectful center, but I believe they are not using it. And what about blood test, which is now used in United States, in Boston? Have you heard, whether you did hear about the pre-TRM study, which they say it's a blood test, and in 5 minutes you will have the result, whether this woman will have risk or not. I believe if this test introduced, it will be better than fibronectin, because it's just simple test, 5 minutes result. You don't need to do taking fluid from the vagina.
Yeah, no, it's a really, really good point. And I think you're absolutely right about shifting the focus to prevention. And from my perspective as well, you know, we know that outcomes are worse if a baby's born with overt chorioamnionitis. So if you look at all of those longer term follow-up studies, actually when there's histological chorioamnionitis, those babies are much more likely to develop cerebral palsy. They're much more likely to develop all of the complications. And actually, you don't want to stop those women going into labour. And we don't have a test for chorioamnionitis in utero. Yes, you can do an amniocentesis and send the fluid off, but that takes time. And I think you're right. So fibronectin, actually, the company stopped making it. And it's a really interesting one. Even though it's good as a predictive marker, they needed some of the components of it to make the COVID tests. So they just revisited their business plan, I guess, at that point, and decided it wasn't effective to keep producing it. But it is good. And I suspect the way the future will go will be much more individualized. So I don't think it will be any one parameter. I suspect it will be looking at factors of the woman's history, looking at cervical length, looking at these biomarkers, like you say, the one in blood, and having a very, very individualized risk prediction score for a woman, because one size does not fit all.
Thank you very much,
Is this
Dr.
test
Lisa.
in the UK used?
It was, but we can't get it anymore, so we don't use it anymore.
Fibronectin test.
حولوا له COVID testing.
Osama, may I have one question, please? Dr. Lisa, this is maybe we can discuss it later. Did you stop giving corticosteroids for patients who deliver between 35 and 37 weeks? According to the last Green Top guidelines, because it's confusing for us.
Yeah, so Green Top guideline currently says 34 to 35 plus 6. And
So
yeah.
you stopped giving corticosteroids?
Yeah, I mean, most of the time we don't give it after 34, to be honest. It's very rare that we would
Yeah.
give it in that situation.
Yes, thank you very much.
Thank you.
All right, thank you.
I would like to invite Dr. Samer Al-Baba, who is Chief Pediatric Neurosurgery, Professor of Neurosurgery at the University of Central Florida, and Professor of Surgery at the Florida State University. And he's going to give a presentation, Fetal in Utero Repair of Open Neural Tube Defects in the post-MOMS trial era.
Good morning, Sabah al-Khair, Allah yatikum al-afiyah for this wonderful Congress. Thank you, Dr. Maita, for the kind invitation, Dr. Annab. Thank you, Mr. Chairman, Dr. Habaib. Greatly honored to be here back in Amman at this prestigious conference. It can be intimidating for a neurosurgeon to be in a group of, a big group of colleagues from OBGYN, but thank you for making me feel welcomed in this wonderful environment. I will give two talks today. The first one is focused on fetal repair of myelomeningocele. We'll discuss the scientific evidence. We'll talk about the where we are today after the MOMS trial. And in the afternoon, we'll focus more on the techniques, differences between open technique and the fetoscopic closure. Yes, all of us in this room deal with spina bifida. For me as a neurosurgeon, I deal with it on a daily basis. And we don't deal with it just at birth. We deal with it for 18 or 21 years, and it's a lifetime disease. This is a global disease. It continues to affect life every single day. Obviously, prevention is the key. The pathophysiology is very complex. It's not as simple as folic acid, but there are some genetic, environmental, and many metabolic pathophysiology. But if we look at the world map, this is a serious problem happening worldwide. Only less than 25% of the world are using folic acid fortification. So you can see on the world map, the disease continues to affect numbers, very high percentages worldwide. If we look here in Jordan, I tried to look at the data. In the US right now, the incidence is between 1 to 2 cases per 1,000 pregnancies. In Jordan, the numbers go anywhere between 4 and 6. And in one of the papers, I found 6.5 per 1,000. Two main complex lesions are open. One of them is the myelomeningocele, which is the most complex type, and the myeloschisis. Myeloschisis is the flat type. Myelomeningocele is the complex saccular type. What is the standard of care today? And I urge you to start thinking about other areas in medicine. 25 or 30 years ago, the standard of care was not to do laparoscopic cholecystectomy. It was not doing coiling of brain aneurysms. Right now, it's the standard of care. We are heading in that direction, and I'll prove it to you scientifically. So the standard of care today, although it's changing, that postnatal repair is the way to go. Typically, it's done in the first 1 or 2 days after birth. Some parts of Africa, it can take up to 4 days. And at our center right now, which is the busiest center in the southeast of the United States, almost 70 to 80% of the cases referred to us on a weekly basis are performed in utero closures. Where's the evidence comes from? There was a MOMS trial, which is the management of myelomeningocele study. This is a prospective randomized controlled trial that ran between 2003, 2011, looked at prenatal repair and the standard of care, which is postnatal repair. And what is fetal surgery for myelomeningocele? It's a team working together, colleagues from maternal-fetal medicine and neurosurgery working together to interrupt the progression of the pathophysiology. This is the key. So what's happening is we interfere with the pregnancy before 26 weeks of gestation. Your excellent expertise in maternal-fetal medicine keeps the mother and the fetus safe while the neurosurgeons are completing the closures for the lesions prior to 26 weeks of gestation. Why do we do it? Again, to reverse the pathophysiology. How does hydrocephalus happens? What happens is as early as 15 weeks of gestation, CSF, cerebrospinal fluid, is leaking through the lumbar defect or thoracic or sacral. This leads to negative pressure effect at the craniocervical junction, leads to hindbrain herniation. In your ultrasound, you see the banana sign. And this hindbrain herniation leads to obstruction at the craniocervical junction, leads to the development of ventriculomegaly and eventually hydrocephalus. And after birth, we have to treat the hydrocephalus. So it happens when we repair this defect, we stop the CSF leak, we stop the negative pressure at the base of the skull, and we start seeing after the fetus surgery reversal of the hindbrain herniation. So the results in the MOMS trial, and by the way, the trial was stopped early because of the positive outcomes. It showed statistically significant rates of reduction in the rates of shunting for the hydrocephalus at the age of 1 year, reduced hindbrain herniation, but most surprisingly, the best surprise that came from the MOMS trial is improvement of the motor function. And that was actually a huge surprise, because an L1 myelomeningocele should be in a wheelchair, now walking with crutches or a walker. An L3 or L4 myelomeningocele now functioning, walking independently like S1. So what they found from the MOMS trial, that the babies who have fetus surgery at the age of 3, they function 2 levels below the anatomical level. And obviously the hindbrain herniation improved dramatically, and almost half of the patients walked independently at the age of 3 years. Who paid the price? The mother, obviously. And you can see here high risk of maternal complications. Pulmonary edema from tocolytic agents, premature rupture membranes happens in 40 to 50% of the cases. All the mothers had to go through a second cesarean section to deliver the baby at 37 weeks. And the average gestation age at birth was 34 weeks and 1 day. That's the MOMS trial. And the biggest risk was the neonatal mortality or perinatal mortality, which was around 10 to 13%. Why? Because there are 13% of the cases delivered under 30 weeks of gestation. So now in addition to the spina bifida, now we added a second problem, which is prematurity. So the take-home message from the MOMS trial is fetus surgery works for the baby, improves motor function, improves cognitive function as well, reduces the rates of shunting, improves the motor function lower extremities, reverses the Chiari malformation or the hindbrain herniation, at this small risk of increased maternal complications, including prematurity. At our center in St. Louis, alhamdulillah, at that time, I worked with colleagues with maternal-fetal medicine. We were the first center in North America to perform fetus surgery after the MOMS trial. And until I moved to Florida in 2018, we did 60 cases. Right now in Orlando, up to 2 weeks ago, we have done 59 in Orlando, and I've been involved in around 12 cases internationally, collaborating with colleagues to open centers around the world. So a personal series is around 130 to 140 cases. But this makes our center one of the busy centers, because in the MOMS trial was 3 centers, Philadelphia, CHOP, Vanderbilt, and UCSF San Francisco. 3 centers did 78 cases in 7 years. Here in 7 years, we have done in 1 center around 60 cases. And we did the first fetal surgery in the state of Florida in 2018. This is Celeste taking her first steps, and now she's happy and walks independently. So what is the impact on the brain? When we look at the studies, look at the ventriculomegaly, we find that after fetus surgery, the brain mantle thickness and cortical thickness increases, and this leads to positive cognitive function. How about the impact on bladder and bowel function? We have no scientific evidence. Why? Because the control bladder and bowel incontinence were not studied in a prospective manner in the MOMS trial for the lack of funding, actually. So, can you go back? So all the data that we have right now about urological or GI impact is all retrospective. The truth is there's no evidence that patients can have better bladder control, but all the studies have shown they can have less severe neurogenic bladder, and I've seen it in my patients. This recommendation came from the ACOG, American College of Obstetrics and Gynecology. Since this came out in 2017, it changed our practice. Since this came out, our office gets referrals every single week. ACOG came out in this recommendation in 2017 that all women with pregnancies complicated by fetal myelomeningocele who meet established criteria should be counseled, let me repeat, should be counseled in a non-directive fashion about all treatment options, including fetus surgery. So, which means when you counsel a mother about spina bifida, you can talk about whatever you want to talk, termination of pregnancy, postnatal repair, but at least you should mention the option of fetus surgery. And this leads to referral to us on a weekly basis. And we saw over the years the termination of pregnancy dropped 70 to 80% because those mothers now are coming and talking to an experienced team of neurologists, neurosurgeons, rehabilitation doctors. So things have changed after this ACOG came out. What are the criteria? The criteria are very strict. So it has to be lesions between T1 and S1. Gestational age should be less than 26 weeks. And when I say 26 weeks, we mean it. The deadline is 25 weeks and 6 days, and sometimes we do the surgery in the afternoon because at midnight, insurance will not even pay for the surgery because there's no scientific evidence after 26 weeks. Amniocentesis is done. In the old days, we used to do FISH. Now we do microarray. And there has to be evidence of fetal hindbrain herniation. The exclusion criteria are very long. No twin pregnancies. Cervical length should be higher than 20 millimeters, as well as lack of kyphosis. We cannot do it first when the kyphosis is more than 30 degrees. And BMI has changed. We used to do BMI up to 35 weeks. Now we're pushing it up to 40 weeks. When the referrals come in, they usually had an ultrasound. We go with an MRI. You can see here on the MRI, the hindbrain herniation, the myelomeningocele, ventricular megaly. This is myelomeningocele, and this is myeloschisis, the difficult type. This is the flat type. There's no sac. And here on axial images on the MRI, you can see no skin, no sac, completely open defect. Amnio is done by the MFM colleagues. And one of the challenges of fetus surgery, we operate on patients we've never met before. So when surgeons go to repair complex spina bifida defects, we've never met with those lesions. So we found that 3D printing actually is very impactful, and helps us counseling with those mothers. And over the years, we maximized the accuracy of those 3D models, and now we have the best accurate model in North America to replicate the spina bifida defects to help us with counseling with the parents. I cannot emphasize enough the importance of teamwork. None of us can do this alone. Without teamwork, you cannot do it. And in the operating room, typically we have 14, 17 people, maternal-fetal medicine, obstetric anesthesia, neonatologists, pediatric neurosurgeons, ultrasonographers, coordinators. You have a huge team. You have the pharmacists on standby outside, 2 neonatologists on standby in case there's intraoperative delivery. And this team approach and the protocol is the most essential part of the fetus surgery. You can do this fetus surgery in Amman today, at any minute. We have the best hospitals, we have the best expertise in all areas. What's lacking in most countries is the team approach and developing the protocols to do this work together. Here you can see in the operating room, there's the microscope for neurosurgery, the ultrasonographer, the level 1 machine to replace the amniotic fluid, the NICU incubator on standby. Strict environment. Once the uterus is out, no in, no out. Mother comes in very early in the morning. First of all, she gets admitted 2 days before for endomethacin injection. Early in the morning, she gets the epidural catheter to help with post-operative pain control and tocolysis. And in the morning, she's placed in lithotomy position. Low finecy incision is done. We scrub together from the beginning to the end. Then we exteriorize the uterus. After the uterus is exteriorized, we start, in some cases, specifically with anterior placenta, we use the Alexis retractor. We localize the placenta. In 50% of the cases, the placenta is anterior. Once the uterus is open, we monitor the heart rate every 3 minutes. Before opening the uterus, every 5 minutes. And there are different techniques how to open the uterus. Up to 5 years ago, we used to have the uterine stapler. The company is not producing it anymore, so now we're opening the old school way. After the uterus is open, with or without a stapler, now we're looking at this uterine opening. You can see the amniotic membrane is sutured and stapled to the wall. You see this tube replaces amniotic fluid. It's a warm Ringer's lactate at 41 degrees Celsius mixed with vancomycin, and this is the myelomeningocele defect exposed. Here are the more difficult myeloschisis defects. We bring in the microscope. I'm standing here between the legs of the mother in lithotomy position. My colleague, MFM, learned over the years how to use microneurosurgery and to assist me, and I learned over the years how to assist with cesarean section. So it's amazing how the team over the years becomes experienced in other areas. Alhamdulillah, in the last 15 years, I've done almost 140 cesarean sections, so I got better at it. And now he knows how to do neurosurgery, so it's a teamwork, actually. We took pride in 2013 to adopt multi-layered closure, closing the reneurulation or retubularization of the placode. This is spinal cord placode, which is flat. We reneurulate it, and here's the dura. We close it, and then the skin. And we start by injecting the cocktail into the fetal buttock. It's intramuscular injection. I'm the one who typically does it. It's a cocktail of fentanyl, vicronium, sedating and paralytic agents, as well as a heart stimulant, atropine, epinephrine. Once we inject this into the buttock of the fetus, we see the heart rate goes the range from 130s to 150s. And we start with the closure. Typically with the closure, we start with microsurgical closure, doing sharp microdissection. My colleague MFM in this case is putting a retractor to hold the fetus in position. And after dissecting the spinal cord placode microsurgically, we inject saline to elevate the paper-thin dura from the underlying lumbar fascia. Then we start by circumferential, sharp elevation of the dura of the underlying lumbar fascia and paraspinal muscles. To go step by step for the young colleagues in the room, the residents, here you can see the amniotic fluid is being replaced, doing sharp microdissection. You look at the diagrams on the top. Now we start with the tubularization. Now we are converting the spinal cord placode, which is flat, into tubular neural tube. So no more neural tube defect. After this is completed, this is done with the microscope. Now the spinal cord has been tubularized. Then we start by, after elevating the dura and the lumbar fascia circumferentially, we do watertight closure of the dura. Then we close the skin after undermining circumferentially. 50% of the cases, the closure can be primary closure of the skin. And some of the cases are not, and we have to use internal skin graft. Those are typically for the wide myeloschisis difficult cases. This is a very difficult case, around 3 centimeter defect, and those are the cases we have to use grafts, skin grafts. After that, we replace the amniotic fluid. We close the womb in 2 layers, and we say to the baby, goodbye. I don't want to see you until 37 weeks. And then the mother, she's closed in a layered fashion. She goes to the women's ICU. As soon as we close, we give her 6 grams of magnesium, and we keep the magnesium for 48 hours, epidural catheter for 72 hours, and typically they leave the hospital on the 4th day. On the day 2, we start seeing fetal hip and knee movement. The first 24 hours, it's like spinal shock. The fetus is not moving. By day 3, we start seeing the ankles and toe movements. We push for elective C-section. At 37 weeks, in most cases, the back is completely healed. We do early functional assessment. Most of the times, if I'm not in surgery, they call me to come to the operating room to do the assessment. Sometimes they call me to cut the umbilical cord. And then we follow the babies in the neonatal ICU. Even cases when we use skin grafts, the way we handle it right now is by conservative management. And it has been 5 years since the last time we took any baby after birth to surgery. As we're becoming more experienced, hysterotomies are getting smaller, our repairs are getting better, and complications are less and less. Even our MFM colleagues, this is a publication from our obstetric MFM colleagues, they believe now that microsurgery is the way to go to help those babies because they can keep the mother safe while we're getting the best outcomes for the patients. Here you can see at 25 weeks, we did this difficult case, myeloschisis, with the hindbrain herniation. At 32 weeks, we do follow-up MRI. Here you can see complete reversal of the hindbrain herniation as well as complete closure healing of the skin. After the babies are born, we do MRIs at 6 months. When we looked at our first 50 cases, we compared maternal, fetal, and neonatal complications. They were all very similar. And actually, it's the same from all busy centers around the world. your outcomes as a busy center will be better than the mom's trial. And when we looked at the first 50 cases, our gestation age was 34 plus 4 days. Now it's 35 weeks. When we looked at the first 50 cases, we do the surgery on average around 25 weeks. The surgery is 3 to 4 hours, but the neurosurgical repair time 43 minutes. 0 maternal mortality, 0 intraoperative fetal mortality. We had 1 late fetal in utero mortality. We think it was an umbilical cord kink, and we had prematurity-related mortality. 60% walking independently. When we look at the risk factors associated with preterm labor, we found that doing fetus surgery under 23 weeks was risky. So now we pushed all our cases to 24, 25 weeks. The learning curve is extremely important. When we looked at the first 50 cases, we divided them into 5 groups. We found in every 10 cases we do, our outcomes are better and better. And we're seeing this worldwide in all centers. We looked at our outcomes for hydrocephalus. At the first 60 cases, we looked at other alternatives, the ETV, endoscopic third with afterbirth. And we found that actually after we do fetus surgery, the banana sign or the Chiari malformation is reversed. We're converting those cases into aqueductal stenosis, and those patients can have great outcomes doing endoscopic third ventriculostomy to help with the hydrocephalus. Our shunting rate right now in Orlando is around 26%, and we're finding that after fetus surgery, there's alteration of the skull base anatomy, and this is leading to improved outcomes for the hydrocephalus. Then, in the last 15 years, the field of choroid plexus cauterization, in addition to ETV, came out. It came out from Eastern Africa in Uganda. I went to Uganda with my colleagues, and we were trained in the ETV and CPC choroid plexus cauterization to control the hydrocephalus. Right now in the US, there's a prospective randomized trial, the ESTER trial, looking at comparing shunts to ETV CPC for treating of hydrocephalus. This paper came out. This paper came out, which is an excellent paper, telling me when I meet with a pregnant mother, what are the predictors that your child would end up with a shunt for the hydrocephalus. Gestation age, if the fetus surgery over 25 weeks, or the ventricular size prior to fetus surgery was 15 millimeters or more, if it was a myeloschisis, or if the lesion was above L3. All those are predictors for you may reverse the high-brain herniation with fetus surgery, but the patient will end up with a shunt. And I never had any mother telling me no. They always tell me, it's okay. I want benefits for my baby. I want my baby to walk, even if you have uterine incontinence or he has a shunt. So the expectations from parents are different. I will shift my conversation about which techniques are better, fetoscopy or microsurgery, for the afternoon talk, focus on fetoscopy versus open surgery. But we are now pushing for smaller and smaller hysterotomies. When we started 14 years ago, our hysterotomies were 7 to 10 centimeters. Now we're doing the surgery with 3 to 4 centimeter hysterotomies. And with better microsurgical closures, we're able to make it even smaller. Can we one day allow those mothers to have vaginal delivery? You will answer, not myself. But training is extremely important. Now we're pushing for simulators and finding training models to help surgeons get trained. We worked with this team in Brazil to develop training modules. What is the future? We're thinking now outside the box. We proved now that open fetus surgery can be safe, can be effective. There's a strong science behind it. It's not a joke anymore. This is the future. This is the standard of care, upcoming standard of care. But what can we go towards other indications? In Sao Paulo, Brazil, now they're doing it for selected cases of occipital encephalocele. And now at our program in Orlando, we opened the program. We're now screening for the first case. Some colleagues in Boston started looking at transuterine ultrasound-guided embolization of vein of Galen malformations with high drops. So we're going outside the box. Now we have the scientific evidence behind spina bifida. Now we're going for encephalocele. Now we're going vein of Galen malformations. Some group in Los Angeles now are pushing to add stem cells to the fetus surgery, but still we don't have enough data. But at the end of the day, the most important is integrity. We need to publish our data. And what's most beautiful about fetus surgery is the NAFNET, the North American Fetal Therapy Network. Every case I do, the outcomes get entered
in a prospective manner into the NAFNet myelomalignancy registry. At any point, I can look at the registry online. I can see the outcomes from any center in North America, and they can look at my outcomes. But the most important is, again, teamwork. Those are my colleague MFMs, Mike Velasquez and Cole Greaves. We are one team. No decisions are made without working as a team, and we become best friends. And it's extremely important to work with a team and to develop the protocols that are best for our patients. International collaborations are important. In the past, we welcome colleagues from Amman, Dr. Saad, Dr. Aqba, I believe, out of St. Louis at that time, and we welcome any of you to come and visit us. And we're welcome to share with any of you the protocol we have. International collaborations are extremely important. Every single fetus surgery we do, we have an international team visiting, so you're very welcome to come and visit. بالدول العربية, we took pride in Dubai in 2020. We did the first fetus surgery with a team in Dubai. But most importantly is tracking the outcome of those patients and tracking them prospectively. And those are the kids I worry about the most. All those kids are walking independently. They had fetus surgery. They're smiling. They're beautiful. But what is their future? We need to track them long term to make sure that they do not develop complications of tethering. And this is a photo we had a couple of years ago for the 5-year anniversary. It's the most beautiful thing to have children running around with happy faces. So in conclusion, fetal myelomalignancy repair worldwide is gaining excitement, gaining lots of momentum. We are heading towards the standard of care, standardization. Technique matters. We'll focus in the afternoon about which technique is better, fetoscopy versus open repairs. And very important to enroll the data and the outcomes into prospective data gathering to track the outcomes and to track which techniques are better. Fetoscopy is the future, but not yet. Fetoscopy is, I will talk to you in the afternoon about challenges related to outcomes or techniques matching what we have right now with open fetus surgery. And at the end of the day, collaboration is the only way to go. Pediatric neurosurgeons, maternal fetal medicine specialists working together to allow improving the outcomes, not only for the mother, but the fetus, the neonate, and the child. And at the end of the day, it's a teamwork. Thank you.
Thank you very much. Time for 2 or 3 questions. Dr.
Thank you so much. Beautiful talk. Just the genetics of the disease. Now everybody's talking about genetics. Are you doing anything to those fetuses? And what panel are you using prenatally, if you're doing it?
Absolutely. So part of the workup, and it's essential, is the microarray. We do amniocentesis, we do the microarray testing, and we look for any deletions or any findings that are abnormal. And most importantly, I did not discuss it today, is the importance of ethics committee. In every fetal surgery center, there has to be an ethics committee, oversees the clinical operations of the team. When a patient comes to us for referral, we do the amniocentesis, and on the microarray, there's a micro deletion somewhere. We get the approval from genetics team and the ethics committee before we proceed with offering the fetus surgery.
So syndromes are excluded by default?
100%.
Okay, so supposedly you do now whole exome. You will not do any case, right? Because with whole exome, you get abnormalities everywhere. And we don't know the value of these abnormalities. So you're just sticking at microarray, correct?
We stick to microarray and we stick to genetic counseling. So the geneticists are highly experienced colleagues from genetics. They meet with the family, they look at the history of the family, and if we find anything abnormal in the microarray, we counsel them again and we go through the ethics committee.
Yeah, Dr. Ahmad.
Dr. Samer, thank you. Full of pride to have such a high caliber doctor in the States. Yes. My question about the anesthesia part for the fetus. How can you minimize the fetal movement while doing surgery? I think this is a very challenging bit.
Absolutely. You can imagine in neurosurgery, we do brain surgery on a patient under anesthesia. This is doing microsurgery on a moving target. So there are different modalities. Sometimes we use the Alexis retractor to help localizing and squeezing the uterus to reduce the movement of the fetus. But most importantly, the cocktail that we inject into the buttock of the fetus has a paralytic agent, vicuronium. So that does short-term paralysis. But at the end of the day, it's positioning. So we try to take extra time with localization of the placenta and the spina bifida defect to make sure that the hysterotomy we do is as close as possible to the defect. Sometimes we do external movement to allow the lesion to be as close as possible to the defect. Making a big opening is not good for the baby, but if you make small hysterotomy, and as you saw some of the videos, my MFM colleagues sometimes would put a retractor under the abdomen of the fetus without kinking the umbilical cord so that the fetus fits perfectly through the defect. Plus the vicaronium injection, plus the anesthesia the fetus is receiving from the mother, all of them will help reduce in technique. The most challenging for me during the repair is the irrigation. And this is when the surgeon has to suck it up and listen. When the fetal heart rate drops down, let's say from 140s down to 130s, 120s, that's when we check the temperature of the amniotic fluid. We have a probe. If the temperature is coming down, the MFM will ask me to stop. I'm in the middle of the repair. Stop, I stop. We do a warm irrigation. We look for kinks for the umbilical cord. Once the heart rate picks up, I come back and continue the closure. And a lot of times, the positioning of the fetus, to keep the fetus in one position without movement by using retractors sometimes puts pressure on the placenta. So it's a constant dynamic environment, but the most essential part of avoiding movements of the baby or the fetus is the paralytic agent.
Dr. Samir, thank you very much for an excellent presentation.
Shukran.
My question is, you know, cost is a big challenge. So I'm sure in the US it's all paid by insurances and things like that. But what's an average cost of this type of surgery in the US?
Okay, before I talk about the cost, let's talk about the global impact. This is the cheapest surgery for any healthcare system worldwide. We're heavily involved now with programs in Egypt and in many countries, in India, and in many countries around the world, and Indonesia, India, and the ministers of health in those countries now want fetus surgery. Why? Because every child in Jordan with spina bifida, from the day they're born until the day they die, they cost hundreds of thousands of dollars. Wheelchairs, shunt infections, antibiotics, scoliosis surgery, Chiari operation, tethered cord operation, orthopedic interventions, rehabilitation, physical therapy, hundreds of thousands of dollars for every child if you look at their lifetime. If you can prevent 70 or 80% of those complications, all healthcare systems found it's the cheapest and the best investment, not only for society, but for the economy of those countries. So insurance companies in the US have zero problems approving fetus surgery for two reasons. Number one, it's cheaper for them. Because if they pay for the fetus surgery and this baby has a 70% chance not to have hydrocephalus and shunt and scoliosis and all those complications, this saves them millions of dollars for this one case. So it is cheaper. The second is scientific evidence. How many things you do in your field, OBGYN or MFM, was proven by a prospective randomized trial? Not many, even in my field. So the scientific evidence before this is extremely powerful. It has been replicated repeatedly. And second, it's cheaper for the insurance company or the healthcare system, and it's better for society. The cost in the US for the operation is, as you know, in the US numbers are not good because it's very expensive. Anywhere between $70,000 to $100,000. But if you have a brain tumor in the US, it's around $300,000. So compared to other interventions, this is considered cheap because there's no equipment, there are no implants, and there's nothing new. You can do it in Amman tomorrow at any hospital. You just need the team and the protocol. So in a nutshell, it's cheaper for any healthcare system, and it's better for society, and the scientific evidence behind it is very powerful.
Yeah. Dr. Ayman.
Thank you for excellent lecture. Is there any place for intraoperative MRI in such cases to make it easier, better for newly practiced neurosurgeons, something like that?
Thank you, doctor. Great question. We do intraoperative MRI for brain tumor surgery and other indications. There is no place for it. Why? Because it's a very volatile environment.
The minute you open the uterus, fluid comes out, bradycardia, this operation needs to be performed as fast as possible, as quick as possible. The clock is ticking. So there's no room for intraoperative MRI because, although we're in the process of installing it, just because of the environment and the lack of benefit so far. This has, again, this is not magic, not experiment. This is proven by science. This is performed every single day worldwide in many centers. In the United States right now, there are 18 centers. Every year we have new ones. In Europe, there are 5 or 6. In the Middle East, there are so many conversations. Colleagues بالسعودية, من يومين كنت في الجزائر, and we always have those conversations with new countries to open new centers. So the most important thing is executing the operation according to science, scientific evidence, and not to try new things outside the box. Thank you.
Thank you, thank you. Thank you. We'd like to invite GE for their session.
Hello. Marhaba. So my name is Hilal Farah, and I play the role of sales and application for Women Health Ultrasound GE Healthcare. Before I deep dive with my presentation, I'd like to share with you one of our features that can facilitate your life, your scanning, out of any transthalamic or transventricular view with the Omni view. And that you draw one line. You will be optimizing the corpus callosum easily. Not only here, for the gynecology as well. It's just a small feature that can help you throughout your busy day. So hello everyone. Again, my name is Hilal Farah, and I'm a specialist application in the region, and I'm truly honored to be here today and to have the opportunity to present the Volocin to such a distinguished audience like yourself. I'd like even to extend my sincere thanks to the Jordanian Society of Obstetric and Gynecology for this opportunity. At Volocin, our mission goes beyond technology. It's about shaping a healthier future for women. Even innovation, we bring it to design and support earlier detection and more confident care decisions by empowering clinicians with the tool that they need every day. Before I begin, I cannot start without sharing this exciting news. One is that GE Healthcare has the highest FDA-approved application built in our systems. More than 100 application FDA approved. This is the first one. And then we have literally taken the application and our system out of the world. They used to say that GE is often described as out of this world. So we did it. Literally, GE is out of the world. So GE launched the ultrasound, and they use it in the International Space Station, ISS. This will give you a clear view how our systems are durable and precise when it comes to image quality. So now why Volocin? Volocin difference is based on dedication to women's health with dedicated engineers, clinical development and marketing team. We are able to partner with our customer, with you, to understand the requirement of changing medical environment. Dedication to women health also allows us to stay in touch with the latest technology and see what you need in order to develop our systems. So when it comes to GE, very good image quality, durable system, dedication to women health, special probe, and what is really important, education. GE Healthcare has a proud legacy of over 4 decades of innovation, starting from the A mode up to now with the graphic flow, with the AI. Our systems are built from scratch to support any AI that's coming to the world. One of the greatest strengths of Volocen is that it's truly a family of systems designed to meet the clinician need and every budget, from entry-level solution to make advanced ultrasound accessible to more clinics, all the way to the premium ultrasound system with this sophisticated technology needed for fetal medicine. I cannot skip without highlighting that it's another milestone I'd like to highlight with you, that the international recognition of our design of innovation, both Volocen Expert 22 and 20, and even the signature 18 and 20 by the Red Dot Award, because of the design and the image quality that we are providing. Moving fast forward to the technology and imaging. When it comes to image quality, Volocen has always set the standard. Our systems are designed to give clinicians extraordinary image quality, clarity, detailed image, ensuring that nothing important is missed. With each new generation, with each new system, Volocen stay ahead of technology, whether through advanced transducer design, powerful processing, or intelligent tools. So doctors can focus on their patient with confidence. This commitment of innovation is why Volocen continue to be trusted worldwide as a leader in women's health imaging. In 2012, Volocen introduced to the world the first HD Live technology. It brings extraordinary depth, clarity, and realism, helping clinicians and parents to see more clear their fetus or their son. But moving forward, GE has introduced HD Live Silhouette. You can see the inner structure of the baby. And again, we upgrade our system for HD Live Flow, for better vascularization with the HD Live. Our latest technology is the graphic flow. As you can see here. With the graphic flow, you can see the trajectory of the flow. In this case, you will not miss any abnormality in the heart. This is our latest technology. It's not only for the fetal and the placenta as well. But when it comes to automation, we have a lot of system of application that can support you with your busy day. Starting with the Sono VCAD, with one 4D view of the heart, you can optimize the 6 views of the heart as recommended by the ESWOG, coming from the 4-chamber, LVOT, RVOT, ICV, and even aortic arch, 3 vessels, abdominal if needed, out of one 4D view. Sonobiometry has been there since like 2007, if I'm not mistaken. Moving forward to the sononuclear translucency for first trimester, and even the intracranial translucency. When it comes to face detection, the SonoRender Live can make even better face detection easier. For the IVF, we have the Sono ABC that can detect automatically all the follicles. What about the Sono ABC Antral? That can even help you to document and see how those follicles are responding to the treatment. AI, artificial intelligence, is all around us, running in the background of our favorite devices, programs, and service. This has accelerated rapidly, and the healthcare industry is catching up. AI has the power to transfer women health ultrasound, and GE Healthcare Innovation are already doing it and leading the market with a lot of AI in our system. When it comes to obstetric, the first one, and this is FDA approved, and this is the newest. Imagine while you are scanning, the system can detect the view, save it, recognize it, save it, and send it to the report. While scanning only. So you reach to the transthalamic. The system will recognize, will do the measurement by parietal and hand circumference, and save it. You don't have to even freeze the image. What was really challenging is the hand and the foot. The system will not recognize if this is the left hand or the right hand. So once you reach to the hand, the system will freeze and ask you, is this the right or the left hand? And you will decide. With that, why I'm saying and emphasizing, because AI will not replace a human, will never ever replace you doctors. It will be as the second opinion. So this is the AI. 28 views, as recommended by the ISWOC, will be automatically detected. This will reduce the scanning time by 40%. Imagine that, and 1 hour exam. With the AI, you will finish by 40 minutes. What about the CNS? How CNS was challenging for us? This is our first base AI in our system. Since 2017, out of the transthalamic, the system can automatically detect the corpus callosum, as you can see here, transventricular, transthalamic, transcerebellar. Not only here, with one button, all the measurements will be there, and it will be sent to the report. This is how we save time. And we reduce by 82%. So it's a lot. With accuracy, this is the most important. When it comes to the heart, we have many, but today I have selected one, the fetal HS. It's a step-by-step guidance that help identify fetal situs and normal fetal heart anatomy by acquiring a Seray loop for the heart. And the system will help you check the angle of the heart if you have the axis of the heart. In addition to the sonobiometry, with the sonobiometry, the sonofetal heart rate that can detect 2 cycles directly and give you the heart rate of the baby. When it comes to gynecology, and nowadays the trend is going toward gynecology, the latest one is the fibroid mapping. Okay, so now let's look at the fibroid mapping tool. It illustrates the position of the fibroid in 3-dimensional, showing their relation to the endometrium, which help us understand the impact on the uterus. Each fibroid is classified according to the FIGO standard, ensuring consistent and internationally recognized reporting. And it can make your life easier by reducing the scanning time up to 88%. Previously, you used to bring a paper to draw everything. Now the system can do everything, and it can be sent to the report. The C-plane of the uterus, with 3 simple steps while scanning with the vaginal 3D. You draw a line, and the system will give you the columnar plane of the uterus. And it will be documented as well. What about pelvic floor? The pelvic floor is AI as well nowadays with GE. With one single line, the system can detect the rest, the contraction, and the maneuver valsalva. Automatically, AI, and it will be sent to the report. I will not forget the IVF, the system with the Sono ABC follicle that can count. Even if you don't want to buy a 4D vaginal probe, you can still use the Sono ABC with the 2D vaginal probe, and we call it autocaliper. So the system does even the autocaliper of the follicles using only 2D vaginal probe. Now probe. I want to share only one probe. I have a lot to share with you when it comes to our probe. But even nowadays, a wireless probe can be connected to our system. We call it the V-scan. We have it either CL, convex linear, so it's 2 probes at a time. You can keep it with you, take it home, or even the SL, the sector and linear. What is the benefit of having CL, convex and linear? Maybe when you are doing the amniocentesis and the patient is away from the system, you can use a wireless probe. We have the voice control. While scanning, you can only talk to the system, especially the signature 20 and 18, and say, hey, Volocin, similar to the Siri, freeze, the system will freeze. Hey, system, print. Hey, system, choose probe number 2. So this is the technology nowadays. So when it comes to AI, imagine nowadays, and because we are here in Jordan, ladies and gentlemen, we are thrilled to announce the new Volocin system, setting a new standard in women health imaging. It's a Volocin performance. Just landed in Jordan, maybe last week. We launched this system this year, 4 months ago. This will not only meet your expectation, but even your budget. It's loaded with all the AI you have seen, the CNS, the Sonolist Live, the fibroid mapping, the pelvic floor, the sonofetal HS. Everything is inside the system. And it will meet not only your expectation as image quality, but even your budget. So with GE, we tailor your need to fulfill the budget you are acquiring or you want to reach. So, this is the launching of the new Volocin performance. This system is really new, only 2 months ago. Best image quality, loaded with the latest AI. Best probes. Wireless can be connected. Radiant flow for the color Doppler. It's the 2nd generation of the color Doppler. And even we have the signature 20 and 18. This is really, we consider it as our high end. Because nowadays we have the premium, the high end with the signature, and even the performance. Fetal HS, Sono IVC. Please. So, thank you so much. It's really our pleasure to introduce you the first Volocin performance and Volocin signature. Thank you. Loaded with the latest technology. Thank you. Pricing, we were tailored. We will give you the best price based on your need. And this is our aim nowadays. We all know that, okay, GE. Yes, you can have a GE with the best performance, best image quality as per your need. This is our main. Thank you.